Good morning, good morning, good morning. It's good to see everybody. How's my sound out there? It's great to see you. KB, Ashley, Alex Gromley. I'm assuming we'll probably have Renee. Oh, excuse me. Hello, Renee. Good to see you too. Ken and I were actually just having a discussion earlier before class, probably 10-15 minutes before class, about some videos I placed in the course resources folder. If you haven't yet, please go take a look at the case of Gerald. He's a schizophrenic, and I've got about 20 minutes of videotape, and it really it's quite an enlightening and amazing piece of video, wouldn't you say, KB? Hi, Needy. Good to see you. Cool. Let's go ahead and get to talk, and if we could, I'm going to go ahead and pull up the old PowerPoint presentation. Okay, so today we're going to talk briefly about schizophrenia. We're going to be talking about mood disorders, and then we're going to be talking a little bit about personality disorders, which we're going to talk about in great detail in the Friday webinar. Somebody sent me actually it was Sarah Gonzalez sent me a text earlier this morning asking about the afternoon webinar. We will be doing the afternoon webinar this week on Friday, so I'll be doing the 10 a.m. show and the 1 p.m. show. Sorry about the inconvenience for the last couple of weeks, but I've got it straight now. So we're going to be doing a 10 a.m. and a 1 p.m. show on personality disorders, where we're going to be looking at your personality disorder, and I'm going to be telling you about Dr. Roddenberry's personality disorders. So let's go ahead and get started. Okay, so if you remember from yesterday, we talked about differential diagnosis, which is disassociating and figuring out exactly which disorder the patient has. Differential diagnosis is done in the medical field too, where they try to figure out if you have a broken foot, a sprained foot, or if you've torn a ligament. The same way that medical doctors do differential diagnosis, so do clinical psychologists. And in fact, KB and I were talking about Gerald earlier, and he talked about disassociating. And Kyle, KB, you mentioned disassociation as a characteristic of schizophrenia. And in the term you were using it, I kind of adjusted what you were talking about. If you think about it, a schizophrenic, they have these hallucinations and delusions, but their sense of self is still put together. They're still an organism. But there's other disorders like dissociative identity disorder, where you have 2 or 3 multiple personalities. And when you meet a person, you may initially say, wow, they're schizophrenic or they have dissociative identity disorders, but you really have to go in and look at the characteristics, the very specific symptoms that they have before you can come up with a truly accurate diagnosis. And why do we want to be perfect with our diagnosis? Well, if you think about it, if you're treating somebody's foot that's hurting them that they can't walk on, if you treat a broken foot and they have a sprained foot, you've made a mistake and they won't be able to walk again. If you treat a tendon and they have a broken foot, they might not be able to walk again. So you have to know exactly what's broken before you can apply the correct treatment. Same logic applies here in the field of clinical psychology. So what are your symptoms that you're going to see in schizophrenia? Well, you're going to see hallucinations, which are perceptual distortions, seeing things, hearing things. People often mix up hallucinations and delusions. Delusion is a distorted belief. A hallucination is a distorted sensory experience. And most of the time, people who have schizophrenia will hear voices. And in fact, Gerald, the schizophrenic, often his doctor talks about him hearing voices all the time. And he's afraid that these voices will tell him to do something that's inappropriate or dangerous. Now, we then have delusions, which are irrational beliefs. And so, Gerald, the schizophrenic, had what we would call a persecution delusion. He thought that the doctors were out to get him. They weren't, but he had this irrational belief. Now, the thing is, schizophrenics some of them will have, there are lots of different types of delusions, characteristics delusions that you will see in people with schizophrenia. So some of them think they're being persecuted, right? Others, people have the delusion that somebody important is thinking about them or interested in them. And so, John Hinckley Jr. Tried to assassinate President Reagan in part in order to impress Jodie Foster, who was a movie star at the time. Wow, how crazy is that? Then there are some people who have identity issues with their in their delusions. So some people will think that they're completely another person. They might have an identity delusion, or they might think that there's someone really super important, like a king or queen. John Nash, a very, very famous mathematician and creator of the Nash equilibrium. He actually won the Nobel Prize for this. He walked into his college classroom one day and announced that he was the king of Switzerland. Right? So he had some grandiose delusions, right? Then there's guilt delusions, and some people we talk about people wearing the tinfoil hats. That's a meme or a joke that you will see, and that's because there are people who think that other people are stealing their thoughts or putting thoughts in their brain to control them. So you're going to see these delusions along with hallucinations. If you looked at the Gerald video, you'll notice that he was very disorganized in his speech. He had word salad and what we would call loose associations. One thought did not follow another. I don't know if any of you have ever talked to somebody and had them switch topics suddenly, and you might laugh sometimes at their non sequitur. Well, a person with schizophrenia is going to continue to have these non sequitur. Their speech isn't going to make sense. They're going to engage in weird, aimless, disorganized behaviors. Gerald the schizophrenic has hair on top of his head, and he's continually twirling the hair on the top of his head. And you know what? They also have flattened or inappropriate emotion. They used to have a diagnosis for what they called catatonic schizophrenia. I don't know if any of you have ever heard the term catatonic schizophrenia, but it's no longer a diagnosis, but it refers to schizophrenics who have motor retardation. They don't move at all. They'll just sit there like zombies or statues. In fact, some of them exhibit this thing we'll call waxy flexibility. You can move their bodies into positions, and they'll stay in the position you mold them into. So sometimes you get flattened emotion, or in Gerald's case, he seemed really excitable and lost his emotions and got very angry and quite quickly. So a person with full schizophrenia is going to have most of these five symptoms. Now, when we do a differential diagnosis, we notice that there are some people who have different collections of symptoms, and they sometimes lead to different diagnoses. So, for example, there are some people who have what we call delusional disorder. If you meet a person with delusional disorder and talk to them for 10 minutes, you will think absolutely nothing is wrong until you ask them about something connected to their deluded belief. And at that point, you will clearly see that this person has lost touch with reality. In terms of being able to hold a conversation, control their emotions, speak eloquently, a person with delusional disorder will be able to do that. But sometimes they'll just have this one thought disorder that drives their behavior. You know what? Some people have a brief psychotic disorder, so they may hallucinate or have delusions after a stressful event for a very short period of time, and then that goes away. Well, even though this person had some hallucinations and delusions, the prognosis, the course of the disease, of the sickness, didn't last like a schizophrenic. So we diagnose them as having had a brief psychotic disorder, right? So you've got schizophreniform disorder, schizoaffective. People have some sort of manic qualities that go along and overwhelm actually their loss of coordination and the strength of their hallucinations. So you might give them a schizoaffective disorder. And you know what? Sometimes people do drugs that cause them to have delusions or hallucinations. And so those represent different diagnostic categories. So when you see a person and they come in and they're clearly not attached to reality and they have some hallucinations and some delusions, the clinical psychologist has to go through this log of questions. Did you take drugs? How long has this been happening? What else is happening? In order to sort of figure out what the course of this is and to figure out what disorder you have. Now, if any of you are interested, there is a new delusion that is taking the internet by storm. YouTube and social media have really fostered this. It's a paranoid persecutory delusion, but Google gang stalking, if you will, and people will take cameras into Walmarts and just they're convinced that people are spying on them, and there'll be 10 and 15-minute long videos where they're commenting on people. See that person, that squeaky wheel is a camera that's taking pictures of me. And the thing is, when you put that on the internet, somebody else has that delusion. They can validate your experience. So there are growing numbers of people who are self-validating each other's delusions on the internet now. And if anybody's interested, I have a news story link about gang stalking that's amazing. All right, now, here's the deal. What causes schizophrenia? Nobody really knows. In fact, really, when you go look at many of these disorders, we're going to do a lot of hand-waving about what actually caused them because psychologists are not truly sure right now. It's some sort of combination of environment, genetics, and biological problems that causes it, but nobody really knows. Remember, I gave you those 3 circles yesterday. It's the social environment, it's the genes, and it's also psychology and learning. You know, really, it's difficult to figure out exactly what causes these kinds of psychological disorders. But let's talk a little bit about etiology and incidence rate because that does sort of give us some clues as to how to treat these disorders and where they may be coming from. So, twin studies show that there is a highly genetic component to schizophrenia for sure. If your identical twin has schizophrenia, you will probably develop schizophrenia too. You have a 50% chance of having it. Now, we do know that drugs that affect that multiply dopamine function, that impair dopamine function decrease hallucinations. So we think that at least the hallucinations and maybe the delusions of schizophrenia are associated with too much dopamine or improper dopamine levels. Now, in terms of the diathesis stress model, the idea that there's physiological insult and some kind of stress, let's start with some biological evidence. MRI scans and CAT scans of brains have shown that there is decreased frontal and medial temporal lobe space in people with schizophrenia. They have a little less cortical space. They have bigger ventricles in their brain, which are the holes in their brain, and so it's thought that maybe there's some sort of cortex missing that leads to the schizophrenia. Now, in that vein, let's follow on with the diathesis stress model. It turns out that schizophrenia develops in late teens. It develops actually, and that's the next slide that I should probably have talked about first, but it's actually going to develop earlier in males than in females, but it's going to develop in your teens or your 30s. If you, as early as your teens and as late as your 30s, if you've seen Gerald, if you've seen someone with schizophrenia, you might ask yourself, this is clearly represents a biological problem in the brain. Why does a biological problem take 25 or 30 years to manifest sometimes? And that's where the diathesis stress model fits in. It argues that maybe people with schizophrenia have some sort of neurological insult. Could be some sort of genetic problem. It could be related to being abused as a child. It could be related to ingesting some sort of neurotoxin or whatnot. But these cause neurological insults in the brain, and this damage leaves the brain in a more fragile state. And so then you become a teenager and you move into adulthood. And I think all of you know what stress is now. We live with stress chomping at our heels all day long. And what the diathesis stress model would argue is that people who have the tendency towards schizophrenia will begin to demonstrate these symptoms once the stress kicks in, once they, and so somebody may fall in love with a perfect person in high school, get married, and have social support that just carries them through their 20s or 30s, and then they get divorced from that person or that person dies, and suddenly the protective factor is gone, and that disorder that was there all the time manifests itself. Now, it occurs in 1% of the population. It is more common in men than women, and its early onset it usually occurs earlier in men than in women. So for men, it's usually the late teens to the early 20s. For females, it's usually 20s to the early 30s. Now, the thing with schizophrenia, let's talk a little bit about prognosis. Like I said to you, one of the things that you do during the diagnostic process is to figure out the prognosis, or what has happened so far, what it's looked like so far, how long you've had it. Because we know that psychological disorders, just like medical problems, have sort of a trajectory that they follow, and that can be informative to the clinical psychologist. And it also sort of, when you get some disorders, the doctor tells you, oh, it's going to be okay, you're fine, no big deal at all. Sometimes you get a disorder and your doctor says, I'm afraid to tell you that this is the end, right? So in a sense, with these prognosis, we also know what the likely trajectory of these disorders are. Now, the deal is with schizophrenia, it does not come out of the blue. I'm not going to wake up tomorrow in a full schizophrenic state. It just doesn't happen that way. And if it did, and I went to a psychologist, the psychologist would want to know what had happened, because this is not how schizophrenia typically happens. There's what we would call a prodromal period for schizophrenia. Prodromal is a general term that talks about the things that manifest before the actual disease gets there. And so there's a prodromal period for schizophrenia too, a set of situations that begin to show you that the person is deteriorating. So they're going to start to socially withdraw. They're going to have difficulty concentrating, difficulty making decisions. And so you're going to see the person degrade over a period of time before they have the first schizophrenic break. So if it's truly schizophrenia, it will never come straight out of the blue. Now, the thing with schizophrenia is it does sort of follow these three broad patterns that I've got right here on the board here. Some people have a schizophrenic break, and it may last a while, and then it goes away, and then never comes back. And you'll see about 22% of the people who suffer from schizophrenia have that particular pattern. The other one, the more common one, is where you have episodes of schizophrenic episodes with episodes where you are functioning normally. So imagine having a schizophrenic episode maybe once every year, once every 2 years, once every 6 months, with periods of normalcy and ability to function in between that. And then you have what we might call people who are chronics, and these are the people who have the schizophrenic episode and never regain functioning. And so these people have to be sometimes have to be institutionalized. Oh, by the way, I did not mean to be rude, Amber. Thanks for showing up today. It's good to see you. All right, so I spent a ton of time talking about schizophrenia and psychotic disorders, and I want you to understand sort of incidence rates and these demographic factors and how they might tell us something about the disorder, and prognosis, what's likely to happen, and some of the causes. So I kind of wanted to walk you through the process, and I wanted to walk you through the process of a differential diagnosis. Now, depressive disorders are one type of mood disorder. So mood disorders is a larger category of disorders, which is people who can't maintain who have difficulty maintaining a mood that allows them to function. So they may be depressive, they may be manic, they may be bipolar, which is manic and depressive. The depression may last a long time and be mild. The depression may be a severe episode that is horrible for a short period of time. Some people get depressed when they don't get enough sunlight in the is in the might not get enough sunlight and might get depressed. I'm getting a text message that there's a technical problem. Can everybody see my PowerPoint? I'm looking at my PowerPoint, but I get a student telling me they can't see it. If you could, type in real quick. Okay. So, major depressive disorder. So let's talk briefly about that. So there are 9 symptoms listed in the DSM for major depressive disorder. They're listed right here. I am not going to ask you to remember all of these symptoms of depressive disorders. I promise you I am not going to do that. All right? But what I want to do but what I want you to do is to see sort of how we do the diagnostic process. So, in order to have a major depressive episode, you have to have at least 5 of these 9 symptoms for at least 2 weeks. Now, we're going to differentiate that and use sort of a differential diagnosis to differentiate what we would call a major depressive disorder from PDD, which is persistent depressive disorder, in which you only have 2 of these disorders, but you have them for a period of 6 months or more. And sometimes people with these persistent depressive disorders may have these symptoms for months and even years. So typically, when you go into the clinical psychologist, they're going to be interested in the number of symptoms you have and the length of time, one being one type of disorder and one being the other type of disorder. If you look at the graph here on the right, I've got this sort of the mood graph showing you graphically what the difference between a major depressive disorder and a persistent depressive disorder is. Now, depressive disorders, most common disorders to people, major depressive disorders occurs in 7% of the population. Depressive disorders mood disorders in general are more common in women than in men. There's actually an interesting distinction. There are what we call externalizing disorders. This is not on the test, by the way. There are externalizing disorders and internalizing disorders. Externalizing disorders are disorders marked by people acting out and doing things. And what you're going to find is that males typically are more likely to have most externalizing disorders, more likely to be schizophrenic, more likely to have conduct disorder, more likely to be an antisocial personality. On the other hand, some people suffer psychological disorders on the insides with the way they think and the way they feel and images in their head of themselves. And what you're going to find is that females are more likely to experience internalizing disorders such as depression and anxiety-related disorders. We do know that drugs that magnify serotonin levels appear to help people's depressive symptoms. So we believe that serotonin is related to mood regulation and depression. That's as specific as I can get with you on the link between serotonin and depression, right? Persistent depressive disorder, less common, but it still occurs in 3% of the population, and it may last for years. Now, I think they say that 20% of us will suffer some sort of depression-related event in our lifetime, making depression the common cold of psychological disorders. Okay, now I want to briefly talk about bipolar disorders, and we're going to talk about this tomorrow when we talk about drug therapy, and we're going to talk about how differential diagnosis affects drug drug therapy. So bipolar disorders is a mood disorder. It's a mood regulation problem, so it still fits in that umbrella of mood-related problems, but the person can't regulate their mood. They go through manic episodes, which is periods of persistent, abnormally elevated mood, grandiose ideas, hyperactivity and racing thoughts, super duper energy levels, which sounds good until you start wrecking things in everybody's life. That's what happens, right? I read a story about a bipolar dentist who got the idea that he was the greatest dentist in the world one Friday afternoon and that he would need to expand his dental office. He couldn't wait for anybody to get a bid on Monday, so he thought he would go in and start the demolition for the project over the weekend. And when his staff got there on Monday in a manic fit, he had destroyed the dentist's office. So you get these manic episodes, and then you get these depressive episodes, which are periods of abnormally low mood, which are going to be similar to the depressive symptoms that we looked on the last chart. And so we've got pictures right here demonstrating how they manifest themselves. And typically you're going to see two broad patterns of bipolar. Some people's bipolar is going to be characterized mainly by their periods of mania. They're going to have the depression, but the mania is going to be the prominent feature, and we call those bipolar 1. And they're going to get bipolar medication plus antipsychotic medication. Some people are bipolar 2, and they're going to have the mood swings, but the strongest characteristic of their disorder is going to be more of the depressive episodes. So they're going to get the bipolar medication too, and they're also going to get depression medication. So the pattern in which you experience these swings between mania and depression determine the course of medication that you get from the doctor. Happens in 4% of the population, typically again begins in late adolescence. A lot of psychological disorders are going to begin in what we might call the beginnings of adulthood. In fact, there's a chapter in the DSM that says disorders typically diagnosed in early childhood because they're different from all the others. So a lot of your common disorders, depression, bipolar, schizophrenia, anxiety disorders, are going to be sort of products of adulthood. And then there are a certain subset of disorders which manifest themselves earlier. Having said that, I did see a video of an 8-year-old child with schizophrenia. I think it might have been on the Oprah Winfrey show or something. So it does happen, but the general course is that most of these disorders are going to begin in late adolescence. Bipolar 1 with the mania is typically diagnosed earlier than bipolar 2. And twin studies show a strong genetic component behavioral genetic studies show a strong genetic component for bipolar disorders. And unlike major depression and persistent depression disorder, this disorder is equally likely to occur in males and females. All right, now those disorders that we've talked about are what we might call ego dystonic. That is, there are things that don't work well with your personality. You know they're wrong. When you're depressed, you don't want that. It doesn't feel good. When you're going through bipolar swings, it doesn't feel good. You don't want that. The schizophrenic person does not want that. And so we'll call those disorders ego dystonic. The problem with personality disorders is that people who have personality disorders feel good about their personality. They like the way they're functioning. So it's really hard to help a person with a personality disorder because their disorder is egocentric. It matches their personality is them, so that is the way they act. You're asking them to diagnose themselves. They can't see themselves. They are the figure and the ground. You can't tell somebody, hey, you have a paranoid personality. They say, no, you just can't trust people. See the difference? You might say, hey, you have a histrionic, overly emotional personality. And you would say, no, people just do mean things to me all of the time. Do you see that? And so most people feel their personality. It's a part of them. And so people with personality disorders are really, really hard to treat. Now, a personality disorder, what's a personality disorder? Because we all have personalities, so it's not like depression. You either have depression or you don't have depression. We all have personalities. The difference is some people have rigid, extreme personality styles that screw up their ability to function at work, interpersonally, and interpersonally with their jobs, their home life, and their ability to function. So people with personality disorders have these really rigid, extreme personality styles. It's okay to be paranoid occasionally. It's okay to be emotional occasionally. But if that is the major facet of your personality, it can really disrupt your interpersonal functioning. So, personality personality disorders, typically they're clumped into three broad clusters, and there are different systems beside the DSM. I'm not going to talk about them in this intro class, but there are different systems of diagnosis used here and around the world, and they all agree that we have three broad clusters of personality traits. Now, within each of these broad clusters, we also have specific personality styles which can be diagnosed, and there is some disagreement about the number and the organization of these styles. So for this test, I just want you to be familiar with this idea of the three broad clusters of personality. Some people's personalities are too odd or prevent them from establishing human ties with other people. They're paranoid or they're schizoid. They just do not have the ability to connect in a human way. I don't know if you've ever met somebody who has trouble smiling or receiving warmth from other people. There are some people whose personalities are so odd that they have trouble connecting with humans. We'll call those the cluster A personality style. Turns out when I took the personality test, I have a paranoid personality. And it's because you students are always trying to get over on me, okay? It's not me, it's you. All right. So some of us have cluster A personality styles. And schizotypal, some people have really odd beliefs, and they're not quite schizophrenic, but they have beliefs that have trouble being grounded in reality. Now, cluster B. Some people have too much emotion or don't demonstrate what we would call appropriate emotional functioning. So we think it is quite normal for people to be able to show empathy and humanity towards others, but people with antisocial behavior or psychopaths do not have the ability to feel empathy, and also have a need to be superior. And this need for superiority and lack of empathy causes them to do horrible things sometimes. Now, it turns out sometimes they're what we call functional psychopaths, and these people sometimes become CEOs and presidents because the same thing that allows you to rise in the business world, ruthlessness, is a characteristic that is consistent with the antisocial personality. Right. And so then there are people with borderline personalities who have trouble with relationships and have a need for other people, and they have very explosive relationships because when people make them feel unwanted just a little bit, they really, really lose their cool and get very angry about that. These are the people that need you to either be with them or all against them, and they have just these explosive emotional personalities. Some people are histrionic, which is just excessive emotionality. People who like to show off too much. Maybe it's that guy that always comes in the tight muscle shirt so that everybody can see his body and stands up in the front so everybody can see him in class, or the female who might do the same, or people who just act emotional so that everybody pays attention to them. And then there are narcissistic personality people who are just so selfish that they can't think of anybody else's interest. Think of an antisocial person as a narcissist with no empathy and impulse control problems too. But all of these clusters have what we might call inappropriate emotional functioning. And then probably the most common that you'll notice, that I notice all the time, are people with anxious or fearful personality styles. Some people are afraid to meet others. They're afraid to go out on that limb because they're afraid of being rejected. These people might be avoidant. Other people are afraid of rejection, so you know what they do? They glom on to people and lose their sense of self. And if I have you tell me what I should wear and what I should eat and what I should like and what decision I should make, then how can you not like me because I'm doing everything you want to do? These people are called dependent personalities. And then there are people whose personalities are driven by obsessive compulsive anxiety. So my dad, if I had to give him a personality disorder, I would say my father was obsessive compulsive, right? He was so compulsive about time. If you weren't 5 minutes early, you were late. If you didn't put all the dishes in the dishwasher, he would have a problem with it. If your room wasn't perfectly spotlessly clean, he had a problem with it. My dad just tended to obsess about everything in his life. So I would say he was sort of an obsessive compulsive personality. Now, it's difficult. On the test, I'm not going to test you necessarily in the individual 10 personality types, but I would like for you to know these 3 broad clusters. Some people's personalities are odd that it's hard for them to make human connections. Some people's emotional functioning is so off that it's hard for them to have human connections. And then some people are so anxious that it's hard for them to have normal human relations. Now, I scored high on some of these clusters. You're going to score high on some of these clusters. Do not let it bother you. We do not have personality disorders because we haven't been diagnosed with the proper tools and by the proper professional. This was just a little bit of fun that I was having. Is everybody cool with that? All right. So that's the end of the lecture. Just remember, schizophrenia involves not just disordered thinking, but disordered behavior and emotions, right? And then I wanted you to know that mood disorders is a broad category that relates to your inability to control your positive mental functioning in a stable way. And then I want you to know that personality disorders are really hard to treat because most people can't see their own personality problem. If you don't have any questions, I'm going to let you go. Thank you very much for coming today. Homework number 8 is available, and you can get started on that as soon as you want. And we'll be talking about Chapter 15 tomorrow. You know what? It was great to see everybody. And I hope to see you here tomorrow for Chapter 15. But till I see you, take care.
Your call cannot be completed as dialed. Please consult your directory and call again, or ask your operator for assistance. This is a recording.